Our lecture today is about burn rehabilitation. Day one of admission. I know the topic is really huge. I've done my best to concise it as much as possible, because this is really needs like a full week course at least. If we talk about burn rehabilitation is concerned with improving quality of life, helping in redesigning and rechanneling of patients' life, achieving the sense of high self-esteem and self-body image. And the aim of the presentation is mainly overview on burn rehabilitation, assessments, and interventions. Also, I will just highlight some challenges and contextual issues affecting health and well-being of burn patients. So in a burn unit, it has a team, surgeons, nurses, dietitians, physical therapist, occupational therapist, social worker, psychologist. Part-time beauty therapist comes, and then she's doing mainly grooming for patients. I know we don't have that in the Middle East, but some burn units in this they do that. If we talk burn injuries are reported per year, 8,000 to 12,000 of these dies, and approximately 1 million sustain substantial or permanent disabilities resulting from their burn injuries. In India, 10,000 burns Saudi Red Crescent yearly in Saudi Arabia. Burns involve 5% of Saudi children. More than 80% of burn injuries are in the developing world and low-educated societies. More than 70% of burn injuries globally in children. More than 55% of burn face hands patients commit or try or even think suicidal attempt due to the acceptance, because they didn't accept their new body. Burn fatality rate in Saudi Arabia is 4 times higher than the neighborhood countries. Maybe it's related to the population and the area, and also the availability of resources, but most of the reasons is mainly because of the informal residual areas. People are going a lot for camping, availability and misuse of chemical substances, and we know that in here, chemicals are sold very easily and very cheaply, and it's mainly used for cleaning purposes or for the drainage of the sewage if it's blocked. So they use chemicals. So chemicals is existing everywhere. Fireworks also is very common in our society, and it's very commonly during our festivals and Eids. Early marriage also is one of the reasons, because the young mother sometimes she doesn't have really the ABCs or the precautions in taking care of the child. Many cases comes like she burned the child while she's washing him or cleaning him or something like that. Child's neglect also is one of the reasons. And the big reason I would say linked to dangerous and inappropriate energy sources easily, like paraffin heaters, wood, coal, barbecuing with gasoline and thin air. It's very common as well. That's one of the most common causes. Electrical burn and using those cheap chargers. We have these ones. The burning issue, if we just summarize it very quickly, burn affect our sense of being whole and how to live inside our body. Body boundaries help to distinguish inner psychological and personal self from the world. A threat to body boundaries compromises psychological self, and resuming life roles, accessing social and employment opportunities are negatively affected with burn patients. The psychosocial care of burn patients is closely interwoven with the physical treatment, compounding the complexity of the total rehabilitation. So if we treat patients, we're not treating patients physically only, but we treat patients physically and psychologically. And this is the key role of rehabilitation team. Lack of coping skills and support system affects psychosocial adjustment of burn patients. I would say in the Middle East generally, the focus on burn patient is not really high enough. Like we don't have enough resources of education, we don't have enough resources of burn associations. That's why there is a lot of defects still in treating those cases. Burn adults reported difficulty in finding jobs as a result of the burn injury. Very minimal chance of marriage, even with other burn patients. I would say in some other countries, they do burn camp. For example, in Africa, we have the Pan-African Burn Society, wherein we have the burn camp once every 2 years, and then we get patients, get them together. So it's a chance also to know each other. So burn patient will not feel alone. He will have a chance to meet with other patients. If we talk about burn rehabilitation, I know this is mainly not all what we are doing, but this is only titles. Like we start with positioning for burn patients, and then we do edema management, splinting, static, and then with the advanced cases, we'll go to dynamic if there is any lack of movement. We do assist patient with assistive devices in case if he cannot use his, if the movements are affected. We do therapeutic and functional exercises. We work on ADLs, ambulation out of bed, and then preparing patient to go ambulatory home. Like I would say, patient, like one of the protocols is patient can go home if he can walk 150 feet on the unit before discharge, unless he has some amputations. The operative phase, like it's the end phase in burn unit, while patient is finishing all his skin grafts, we can start scar management. Scar management include a lot of various techniques and interventions. I would say simply we start doing wound care for the small, tiny scattered wounds that OT or PT could manage, like wound and skin care we start with. We do scar mobilization, soft tissue release, moisturizing, early, low to medium tension of pressure, and this could be done through interim garments or bandages. And then we use a custom-made grating compression therapy. We use silicone gel sheets, and then all over the stages of burn patients, all the phases, we are still working on the psychosocial support and mental health as well. But the rehabilitation team will help and give some advices and give some materials to use. And the burn position is mainly the head should be in a good alignment. If there is burn in the anterior chest, neck, their pillow shouldn't be used at all with these cases. Shoulders should be abducted maximum 90 degrees. It shouldn't exceed at all the 90 degrees. Arms could be elevated with this hand splints on. This is very important. Like the earliest splinting we do is mainly hands and feet, because the feet should be 90 degrees of dorsiflexion. Hands, rest should be, I would say, 20 to 35 degrees of extension. MCBs, 50 to 70. Finger should be in extension, and thumb should be in the maximum palmar abduction. And the most important as well is to maintain the C shape of web 1. Hip should be abducted 20 degrees, and this is mainly the best position for any acute burn case. That position will really help a lot to minimize edema, because there is always massive edema on the admission when patient comes. it continues the nursing issue, but still the OT, PTs are helping with some advices. The first photo on your left-hand side with the severe anterior chest burn, you can get a rolled towel and then put it along the spine, and this will help not to have like will prevent contractures future-wise, so patients will not get kyphosis easily. In positioning as well, you can use like wedges, or you can use the side tables for the shoulders. Splinting is very essential. Like if you are a burn therapist, you should be really familiar with a lot of splinting techniques, and as well as how to splint on heavy dressing or thick bulky dressing. And this is, you will get it by experience as well. Splinting generally is a science, technique, and art. And it's not only a matter of thermoplastic material you apply in patients. And the burn therapist must be aware of the anatomy and the kinesiology of the body parts to be splinting prior to fabricating a splint. So splinting devices are vital in burn rehabilitation as they are utilized through the patient's recovery in obtaining appropriate positioning of the entire body. No matter how the therapist approaches splinting materials, designs, or application, and the goal is mainly to bring about the best functional outcome at the completion of the rehabilitation process. For example, the one on the right top, this is an aeroplane splint. This is the easiest and the most comfort splinting design you can apply for abduction of shoulders. It's a two pieces of splint, and then it has a bar in the middle. This is very easy to apply for nurses, for OT, for patients, for family action, but not more than that. Because if you put the shoulder in more than 90 degrees for a longer period of time, patient will easily develop radial palsy. So in the inpatient setting, we mainly use static splinting because the skin integrity will never tolerate the dynamic splint. I will go through dynamic splint if patient's skin is completely healed, if the skin integrity is high enough to tolerate the tension of the dynamic splint. You can see the one on the top, the foot on the top. This is a dynamic splint for the little finger, and it's mainly used, I would say, if there is hyperextension in the MCB, because usually the MCB in the little finger is the worst, and it's always the start. But I will use that type of splint if I already started pressure garment or if I already started co-banning. The second photo is a flexion glove. It's a soft leather, and patient could apply it at night just to facilitate flexion of the hand if patient flexion is limited. But I wouldn't do the flexion glove and getting the BIP joints in flexion unless there is a complete healing of the PIP joints. There is no fragile graft on the area, because you can easily MCB knuckle. I would say this could be used as well, like future ways. Patient could use it during his ADLs and functional activities, and it mainly keeps some flexion of the BIP joint. Mind, like the splint shouldn't cause any pain. It should be functional. It should be cosmetically appealing, easy to put on and off. Should be used, like, for example, I will not use a Polyflex material to fabricate a safe position splint, and it should allow some ventilations. This is mainly some photos, like the photo in the left top. This is a POSI splint, and this is mainly we use it for dorsal hand burn or circumferential burn. And I know the photo is a bit extended, but the rest should be in 25 to 35 degrees of extension. MCB 50 to 70, I would say if you can go to 70 with this, will be really good. Fingers should be extended. thumb is in the maximum palmar abduction. With arm burn or mainly anterior burn, mainly if it's affecting cubital fossa or near elbow joint, you splint the elbow in extension, keeping in mind that you need joint in full extension in splinting. You should allow some 5 degrees of flexion. Because if you block the joint space, could cause heterotrophic ossification. Could be one of the reasons to cause heterotrophic ossifications. Another safe position is splint. You see the first one, we use bandages, because if you splint patient while patient hand is badly edematosed, better to use AC bandage in a figure of 8 to secure the splint, because initially with burn patients, the splint should be applied like all the time for the first 48 to 72 hours. It should be all the time. Once the edema is subsided, you can go with the strapping. And if you go with that splint, blue boots are commonly used as well to position patients' feet, even if the lower limbs are not burned. Our patients stay too long in the bed, and if they're in a bed for a long time, sometimes patient comes with, for example, 30% burn for upper limb, nothing in the lower limb. But maintaining the feet in a proper position, will prevent drop feet future-wise. That one is a mouth splint, and we have some other designs in our facility, dynamic ones, wherein you can stretch the mouth if there is a huge burn on the mandibular areas or around the mouth. The mouth splint is very important to prevent microstomia, because microstomia is very common with facial burn. This is another extension splint with elastomer inside. Elastomer is a type of silicone. We apply it with some cases, some areas, some joints, especially with contractures. Palmar burn, the best for burn patients to rest at night in a splint like that, and then padded with elastomer, and then in the morning patient could apply the pressure garments. Dynamic splinting, as I mentioned, it should be done in a later stage if the skin integrity is strong enough to tolerate the tension. Like this is another version of flexion glove. You can get just an isotonic glove, and then you can apply those TheraBands. It comes also ready-made. If you don't want to waste your time and fabricating that, it comes ready-made as well. Another splint, that dynamic splint, wherein you get all the fingers in flexion, and if patient feels discomfort, he can move his hand. So it's a dynamic split. You've noticed that I didn't apply that split unless I apply the pressure garment under first. So the pressure garment gives protection to the skin, and the tension will not really affect the skin. Then in neuro, I would say we call it antispastic splint, wherein you can get it as a bucket. You can get integrity also. If the dressing is done, if you start cobaning for the hand, because you will have a different bulk dressing from day to another. So the splint might fit today, but it might not fit tomorrow. But if you apply cobaning, you also maintaining the fingers in a straight position, rest in extension, MCB in the maximum flexion. If we talk about therapeutic exercises are very important for burn patients. Exercises are important to decrease patient, and this will help in reducing joint adhesions. Also will decrease tendon imbalance. Exercises are very important as well to decrease the contractures development. But please, I would consider always gentle exercises with burn patients. Those aggressive stretching, and we always should depend on the tissue elongation principle. I would say in the first 40, mainly positioning and splinting. This is to start with. And then after 48 hours, edema will be the full extension. Repetitive exercises for sedated patients shouldn't be too many repetitions, like very few repetitions, very gently, just to be sure that the joint is well mobile, but not to do a lot of repetitive exercises while patient is sedated and intubated. I would do like 5 repetitions, very slow, very gentle. Exercises should be low load. It should be prolongated, elongated, stretching. If there is tightness of the skin, if there is tightness, I would do stretching, but very prolongated and elongated. It should be very gentle. Exercises for burn patient could have a lot of complications. You can have a lot of issues with burn patients, like skin fractures and laceration. It's very common with aggressive exercises. That's why laceration due to aggressive exercises. You can easily have tendon rupture. For example, if you are exercising the hand, BIP joint and DIB joint, never do passive range of motion exercises for these fingers. It's completely prohibited. The only joint who can exercise with dorsal burn hand, MCPs, thumb, opposition exercises, rest, extension flexion, but PIP, soft tissue damage, we could do soft tissue damage as well if we exercise a patient while there is a massive edema around. Better to get rid of the edema first and then you can do your exercises. With heterotrophic ossification, I will stop here for a while because there is a lot of researches, there is a lot of papers and evidence-based about heterotrophic ossification. We know you will always read heterotrophic ossification has not a specific reason, but with our experience in our burn unit, I would tell you heterotrophic ossification, one of the most important cause is aggressive exercises for HO. Heterotrophic ossification is very common in bedridden patients in ICU, post-head injury, the most common joints. It could also happen in the hip and the TMG joint. If there is a huge face burn, it's really, the main reason is really aggressive exercises. Aggressive exercises is really causing heterotrophic ossification. And I could tell you easily, since I work in burn unit, like if we have an X person work, because I know that person is doing aggressive exercise, that person is not doing aggressive exercises. That's why we should be very gentle in exercising patients. Exercises also, if it's really painful, especially with burn patients, you will really cause a lot of psychological illness and compliance with patients for the treatment. That's why we really need to work very gently. Another thing I would say about the evidence-based, if you start pressure garment, some papers says you should take the pressure off to do your exercise. I would easily get more range than without, because pressure gives the a feeling for patient as this is my second skin, will be more comfort and you can easily exercise patient nicely without pain. CPM machine, we can use it for the hands, and I would say also I will use it if the skin integrity could tolerate the CPM machine. And we mainly use it if there is some stiffness in the MCB flexion. I would prefer the MCB because it really facilitates the range of motion. You can do it, start with gentle, and then you can increase the flexion. Every 10 minutes, you can increase more flexion. E-Link machine is one of the best machines you can use to exercise patients. And the E-Link initially started with the upper limb exercises. So you can exercise hand, wrist, elbow, shoulder through computer games, like patient is having a special handle, and then with the you can increase the resistance of each game, so patient is gonna exercise while he think that he is playing. Nowadays there is the new e-link machine that you can exercise upper and lower body exercises through that machine. So it's really a very nice machine. I would really prefer that any burn unit or even burnout patient should have that machine. It will save a lot of your time. You can put the patient on the machine and fix it and put it in the resistance you like, and then he will exercise through it. You can get the score, you can get even an AMG by feedback about the exercises. And it also has an assessment tool wherein it will measure the range of motion for each joint for you. So it's a very useful machine that it should be around, and especially I would say for pediatric, like pediatric or even stroke patients and burn patients. It's a beautiful machine. Now we'll talk about scar management, which is really the big topic of burn patients. Scar management, as I mentioned, we start in the recuperative phase with the scar management. Scar management is a process that continue for at least, I would say, a year. Like any burn patient will take a period from 1 year to 24 months of scar management post-burn. And with dark skin patients, I would say sometimes they take up to 35 months of scar management. Scar formation is a natural part of the healing process and occurs when the skin repairs wounds caused by burn, accident, surgery, or diseases. Scarring occurs due to permanent disruption of normal skin architecture. I would say easily why patients form hypertrophic or keloid scarring post-burn. It's simply because of if you go through the wound healing phases, we have the hemostasis inflammatory phase, the proliferative, and we have the maturation phase. During the maturation phase, wherein it starts after the graft, there is some cells called fibroblast cells and macrophages. Those cells are working, they are very active post-burn. Also, the blood supply is very active in the scars, in the newly formed scar. The fibroblast, it's the cells that responsible for collagen deposition. But what happened after burn, those fibroblasts produce collagen that equal 4 to 16 times the normal collagen deposition. And this collagen keeps accumulating in the new skin up to 2 years. With the accumulation of collagen, the skin gets thickening, and then patient will feel with very, very severe pain. So expect when patients start to move around, he will say, oh, I have a lot of pins and needles pain. And sometimes the best description, they say, sometimes I feel like 1 million mosquitoes are biting at the same time. And this is mainly because of the collagen deposition hits the nerve endings and cause this severe pain that really disturbs sleeping. So even if burn patient is not having joint involved, like you will be sure that this patient will not develop contractures, but still those patients without good rehabilitation, they cannot sleep with this pain. The only thing that could help with reducing that pain is the scar management. And for scar management factors that affect the scar formation, like not each patient will develop a scar with the same amount like the other patient. Like the severity of the scar formation will depend on the prolongation of the inflammatory and the proliferative phases of wound healing. That's why if you listen the phases, patient will have better scarring, but still they will develop scarring. Any patient who has his wounds open for more than 20 days, he will develop hypertrophic scarring. The prolongation of the inflammatory and the proliferative phase will depend on the depth and the severity of the burn, edema formation, wound infection, prolonged healing by secondary intention. Like those patients who refuse skin graft, they will have worse scar than patients who are grafted. Immunological foreign materials present in the wound, simply infection. If the wound gets infected, these patients will be having worse scarring. Age also is one of the factors that affect scarring. Like skin healing is slower in older, while younger skin tends to overheal, forming larger and thicker scars. Genetic factors, skin types, I mean, like people of African and Asian descent, usually, or I would say highly pigmented skin patients, especially prone to abnormal scarring, like keloid, rather than hypertrophic. And we will know the difference later on between both. Skull location is also important because I would say upper back and chest is one of the areas that develops very, very bad scarring. And this is mainly because it's particularly an active area. Areas like ear lobe, also one of the areas that have keloid scarring. Palm and soles tend to have more contracture than hypertrophic scar. Same with eyelids. If the eyelids are burned, you will have an ectropion, which is really a contracture of the eyelids. I would say also that type of meshing that the doctors did also will be one factor of scarring. Like if the meshing is 1 to 2, it's gonna be less scarring than if the meshing is 1 to 6, for example. Reasons for scarring, just to summarize, it's due to increased and prolonged inflammatory response, increased vascularity, because blood supply, excessive blood supply in the burn area will be one factor. I would say simply it's the food for the fibroblast to deposit more collagen. Increased collagen synthesis with corresponding decrease in collagen lysis, and also increased adhesiveness of collagen fibers, plus increased myofibroblast and contactile factors. If we talk about type of scarring, number one, hypertrophic scarring. And the hypertrophic scarring, it's characterized always by the 3 R's. The 3 R's means red, always the scar is hyperemia, it's always red in color, raised because it has excessive collagen in the area, and also rigid because sometimes it's with neglected hypertrophic scar, it goes rigid and it's really hard to move it. So you cannot have easily skin movement in the area, and this is what will affect the joints of the burn is falling on a joint or near a joint. This is some photos of how the hypertrophic scar will look like. The one on the left-hand side, this is a donor area. Donor usually shouldn't develop scarring, but we consider always donor site as a superficial burn. Sometimes donor site makes very bad scarring if they take a deeper portion of skin graft. This burn, for example, it should be causing a lot of pain for patients. The type 2 of scars is keloid scar. And I'm sure many of us met a lot of patients with keloid scars. And the word keloid itself, it's derived from the Greek word means keli, meaning the crab's claw. It's always thick, very thick scarring, puckered, puckered and clusters in shape, like it's each cluster of scar tissues that grows beyond the edges of the wound or the incision. Like, for example, if you have a keloid scar in the chest, for example, sometimes you can put your hand between the keloid and the good skin because the keloid makes pockets in between. It's very nodular in nature, and they're often darker in color than surrounding skin, and frequently occurred with patients with dark skin. Like patients with high melanocytes are more liable for keloid scarring than the fair skin patients. This is a keloid. This patient is not burned, but this is just to show you. This is post-ear piercing. And if ear piercing is infected, imagine this could be a result. The keloid will develop very quickly, like within 3 months, patient could have that bad keloid. This is a patient post chemical burn, and you can see the edges. Those edges, you can put a little bit of 1 centimeter of something in between because it makes a pocket. This is one of my patients. You can see the keloid, how it forms. This is my hand. I can put my finger. It's falling like a grape. You can see it, how bad is it? It's really bad. This is patient referred to as also post-cholecystectomy. You can see how massive the keloid is. This is only sutures, I would say. Another burn patient with keloid scarring. You can see it starts forming buckets in the edges, and it's really raised and firm. Another patient of mine, also keloid on the face. You can see, I know the neck is not involved, but you can see patient, while he's rotating the neck, there is some stretching in the neck because it's not in the joint, in the neck joint itself, but still it's affecting the neck movement. This is another patient of ours as well, and you can see the amount of affecting the elbow as well. So it has a keloid and contracture. This is another burn patient. Also, this is a thigh, and imagine the way it looks. That's why it's like they call it clusters in shape. The third type of scarring is contractures, and the word itself explains the type of that scar. It's contracture scarring, and this is mainly permanent shortening of the muscles, tendons, or scar tissues, producing deformity or distortion. And contractures form due to scarring that pulls the edges of the remaining skin together. Also often restrict normal joints and body movements. Contractures occur very fast post-graft if patient is not splinted well or if he doesn't have a good proper rehabilitation intervention. This is like you can see the first on the left. This is severe contracture, flexion contracture of the wrist. The one in the middle, this is severe claw hand due to dorsal burn. And you can see the other one. You can see the web space, the web 3 is completely melted, like web 3 is completely gone, and with flexion deformity of the index finger. There is a theory also about burn contractures. Like if patient is neglected for 1 to 4 days, he could develop easily scar contractures. And contracture could reach the tendons and the sheaths from 5 to 21 days. And muscle shortening after 2 to 3 weeks. If it affects ligaments and joint capsules, and this is what happen from 1 to 3 months. So burn patients shouldn't be neglected at all, because this is mainly the what will happen for if joints are involved. I would say some changes in the bone structure as well could happen. Like for example, you can have easily if a patient has a trunk burn, like I have one case like 6-7 years ago who has burn in the right flank, and imagine that patient have sideway flexion deformity, and he develops a scoliosis in his back because he was neglected for a long period of time without scar management. This is mainly some photos of the scar contractures, like this is neck contractures, again neck, and in the right photo, this is a true case wherein the burn pulled the lower lip down, and then the neck is completely gone. This case is really difficult to treat. The other one was treated nicely. This is another patient who has flexion deformity of the elbow, axilla, elbow, flexion of the wrist, and flexion of the hand as well. Because of the Balmer burn always develop flexion deformity. That's why with Balmer burn hand, the splint should be an extension. Another hand that glowing. So this is contractures in the extension contracture in the MCB joint, and it's pulling the PIP joints in flexion. Flexion also for the little finger, claw hand, and this is not one of my patients, but I would say this patient is existing. We've seen a lot of cases like that, and this is mainly neck contractures, axillas. You can see the axillas completely melted. Like this patient has no shoulder abduction at all, and you can see the elbow flexion as well. You can be pulled even down more. One of our true patients, the neck is completely melted with contractures as well. So scar management, what we do? So we do some subjective assessments. Our subjective assessments include various factors that contribute to the patient's own evaluation, visual and tactile contributions, which include both perception and body image as well. Objective measures for scars include physical characteristics of the size, shape, volume, color, texture, and probability of the scars. In addition, it also you also assess the structure, mechanical, and physiological characteristics in the skin. There is a lot of assessment tools, I would say, or skills that assess the scar. Like there is a visual analog assessment scar, but usually and the most commonly used method to assess a scar which we are using is mainly the Vancouver scar scale. The Vancouver scar scale assess mainly biliability of the skin, the height of the skin, the pigmentation, and the vascularity. The biliability is mainly the elasticity in the skin. Like if the biliability is 0, it means it's a normal biliability. And this is, you can easily know it by touching the skin and giving some pressure with your hand on the skin. If the biliability is 1, means the skin is really subbling. If it's yielding, I would give it 2, score 2. Yielding, I would say leathery. If the skin is getting leathery, it's yielding. If it starts forming hypertrophic, it will be more firm, so I will give it 3. If it's adherent, especially burn over dorsum of the foot, dorsum of the hand, sometimes they get more adherent scars than firm scar. Also burn due to degloving injury, like burn due to friction burn also, because there is always soft tissue damage as well, so sometimes the scar gets adherent. If it's 5, means there is contracture. If you have a patient who has a firm skin and contracted at the same time, you will mention in your notes biliability is 3 to 5. If we go about height, the height also you can measure it with a transparent ruler. Also, you can estimate it with your eye and your hand as well. One, if the height is 1, it means the height is 1 to 2 millimeter. 2, it means 3 to 4 millimeters. If it's kiloid, it's always 4, because 4, score 4 in height means it's more than 6 millimeter thickness. And if we talk about kiloid, sometimes it reaches to 2 to 3 centimeters thickness. Imagine. Pigmentation is always the amount of darkness, or the amount of the melanocytes of the burn area. Most of the burn graft is always dark, but usually patients will have mixed pigmentation. If it's mixed pigmentation, you will put your pigmentation as 2. If it's hypopigmented mainly occurs both surgical procedures or with patients whom their burn healed with secondary intention. It means if the burn healed without surgery, without grafts, mostly it healed with the hypopigmented skin, you will feel like the skin is very whitish. And then you can score 3 for the very badly hyperpigmented skin. Vascularity, it's one of the tools that you can measure if the scar is active or not active as well. If you measure the vascularity as 0, it means this is normal vascularity. And if you measure it as 0, I would say, okay, it means we finish our scar management intervention. If it's 1, pinky. If it's 2, it means it's red. If it's 3, it's always purple or blue. Sometimes it turns blue, purple, black. So patients post-graft, they usually have very high vascular skin. And then after the complete healing, they have this flaring, I would say, flaring stage of scar, wherein the vascularity is very, very, very high. This is mainly the 4 elements of the modified Vancouver scar scale. But I would add to our assessment is pain, because pain is one of the most important complaints of burn patients. And that pain is mainly scar pain. And as I mentioned before, scar pain could be intolerable. It could disturb their sleep. The only thing would help with pain is pressure garment and skin moist and stuff like that. Also, we measure itchiness because scar gets very itchy. Sometimes patients cause a lot of wounds due to this itchiness. And then I would add to the assessment of the Vancouver, I would add the functional limitations. So this is mainly the assessment tools of any burn scar patients you will have. So what we use, we keep saying about pressure garment, pressure garment, pressure garment. Pressure garment is mainly developed by Larson Upson Evans in 1971 at Schreiner's Burn Institute, Galveston in Texas. And the way they discovered it, they had a burn patient, lower limb burn. Patient is having massive edema and severe pain in the lower limb. So what the therapist did, he did AC bandages, like he did bandages on the lower limb to reduce edema while patient is ambulating. And then they left the bandages incidentally, like they didn't mean, they used to put the bandage, remove it after each time they ambulate the patient. They left the bandages on the patient because patient said, I feel more comfortable with that. The second morning, when they take it off, they notice that the edema is gone. And this was known before, that pressure bandages is good to reduce edema. But they discovered that the scar gets a lot less and it gets more flat. And at the same time, patient said he could be able to sleep with no pins and needles pain that he used to sleep with. And the amount of pressure you apply on a patient, it's mainly depending on the Laplace equation of pressure garment. And that equation is well known for any burn therapist or therapists who are working with lymphedema. And that equation, we use it, I would say, you will be used to it if you are familiar of using bandages, also with the factory that fabricate the pressure for you. So the amount of pressure, like for example, if you want a 24 millimeter mercury pressure, how they will get that? They will get it by this equation. So P stands for pressure applied by the garment. T is the tension within the garment material itself. And K is a constant value dictated by the measurement system. And it's usually 0.0047. And R is the radius, the size of the limb that we as therapists are giving it to the company. It's mainly the circumferential measurement we are giving. So what pressure garment do for burn patients? It causes reorientation of collagen fibers to elongated parallel patterns. It reduces the blood flow to the raised scars. It reduces the cohesiveness of the intercollagen fibers. It increased the vesicular fibroblasts and decreased mast cells. Also, it results in hypoxia, which causes fibroblast degeneration and altered collagen metabolism. It also results in soft biliable scar. It's also working as pain relief. I would say if you apply pressure garment, it will be 90% better than the Atarax medication that the doctors give for burn patients to be able to sleep. It also provides protective shell to delicate scar tissues, so it gives a protection for those cells. It's also promoting social interaction, and this is very important to promote the self-esteem and improve the body image. Like patient will be always hiding behind pressure garments. You can use a lot of materials for pressure garment. I would say AC bandages. If you don't have any way of pressure, you can apply AC bandages. But you need also to consider the amount of pressure. Like the pressure should be more or higher on distal than proximal, and you should do it as grading, so it will help and facilitate the blood supply and blood return and fluid return. So if you apply it, you should consider that theory, higher pressure distally, and then gradually you lower your pressure. You can use tube grip as well, and there is always ways to measure what the best size of tube grip you could apply. Tube grip, it has a special measurement tape, or even it's written in the box also. If you don't have the special measurement tape, you can use the guide on the box how to measure a patient. And the tube grip also you could apply a very good pressure with tube grip. Like you can go up to 28 millimeter mercury of tube grip. Cobanning, I would say this is our magic tape that we're using, especially for early intervention for hands. Like if the hand is burned and grafted, we can start cobanning from day 10 post skin graft. If the graft is well taken, you can do the skin care, wound care, and then on top of that, you can start cobanning, because this will really facilitate quickly the movement, and it will also reduce edema, and it will fasten the healing process. Interim pressure is very useful, especially if you start pressure while patients still have some scattered wounds. Like the nurse could do the wound care, and then you apply the interim pressure after. And early pressure interim will give very low pressure, so it gives like 15 millimeter mercury to maximum 24 millimeter mercury. It doesn't give more than that. And you can start it in the inpatient setting if patient finishes skin company to fabricate pressure for you. But still, with custom-made pressure, I will not apply custom-made pressure or like custom-made pressure. It will give more resistance on weak muscles, so patient will not be able to move good. So better to prepare patients' muscle power first before applying those garments. You can still continue with the interim till patient will regain his complete function. So pressure garment is not only an elastic material you apply it on a patient. It should have a lot of specifications. Like if you choose the design, you should consider the location of the burn, location of the donor side. Like for example, if patient has burn on the thighs and the donor is the tibial area, you cannot apply only a pressure short on a patient. You need to apply a full trouser, and then when the donor is completely mature, this is the time you can cut the trouser to be a short. Because if you apply higher pressure on the thighs, blood supply on the donor area will be more, and the scar formation will be more in the donor area, which was the tibia, for example. Also, the stage of healing, we need to know where we are and what type of pressure we should apply in this stage. And we should consider the tensile technique of applying pressure, how to apply pressure without causing friction, how to apply pressure without causing laceration. Are we in need for extra foam lining for the garment or not? Should I add the spinco foam on the axillas, for example, on the anterior elbows, posterior knees, anterior ankles? Sometimes we add excessive foam dressing to work as shock absorbers, so the pressure will not be causing any digging in those joints. Pressure should be worn, should be or more 24 millimeter mercury. I would say this is the lowest, I would say, like 24 millimeter mercury for pediatric cases. And for adult, it should be between 28 to 32 millimeter mercury. It must be maintained for a minimum of 18 months. I would say 18 to 2 years. This is the good scar management period that patient could wear the garment for. And for showering, skincare, applying moist, doing deep friction massage or do soft tissue release, and then applying silicone and then pressure. Garments material should suit the area climate. Like if I'm working in the Middle East, for example, I will not get a pressure garment that doesn't cause respiration. For North America, for example, but it doesn't suit our climate because we have a very hot climate. So the material should be containing lycra, micro silk, because this gives a lot of cool on the skin, will be cool in the skin, and it also contains some cotton, so it will absorb sweating if there is a sweating under. And also could be a weak point where inpatient pull the garment on and off. It could easily break the material. And the most important as well, the thick seams always make digging on the skin, which it's really causing pain, and sometimes it causes laceration. Zippers are not really recommended and future pressure. That's why zippers are not recommended. So the best is to have hooks than zippers. Pressure garment doesn't have many complications. Like it has very minimal complications. Most of the complications, I would say, if it's only like wrong measurements or something. But in children with facial burns, pressure garments may lead to skeletal and dental deformities. And that's why with patients who wear pressure mask or chin strap, I always advise patient to maybe chew gum while garments should burn. I would say I would prefer 2 pieces pressure garments, one anterior and then a chin strap. Also with patients that have severe peripheral arterial disease or septic phlebitis, it's not really necessary to apply pressure, but you can use other techniques of scar management. It's very difficult to apply pressure garment in obese patients. Not difficult for us to put on, but whatever the amount of pressure you apply, it will never give you the volume pressure you are aiming. That's why a case like that, I would apply a non-pressure technique of scar management rather than applying a vest, because whatever pressure you apply, it will never give you the pressure you want. In very severely deformity patients, it's really difficult to apply, especially for hands like that. So in that case, I would use more co-banding and teach the family how to use than like a pressure glove, for example. Scar maceration and laceration is one of the complications that we used to meet with burn patients. And if it happened, it usually it's due to friction between the garment and scars. That's why before applying garment, you should be familiar of the techniques, how to apply garments on and off. Also, you can use some assistive devices like easy slides to put on garments easily without causing any friction. Poor patient hygiene is very important, because if patient hygiene is very poor, maceration or تعفن الجلد is commonly existing. Skin sensitivity also is one of the reasons that could lead to scar laceration or maceration. Tightness of the garments over underlying joints, and I would say mainly anterior knee. Sometimes the pressure causes some digging on the anterior ankle, posterior knee, anterior elbows. This is the most areas that cause tightness of garments over those joints. Also for axilla burn, I would really always prefer, if you request pressure garment for a patient, like a pressure vest, always tell the company to apply extra foam lining for the axilla. The extra foam lining for axilla lessen the digging or the tightness of the garment on the axilla, and also will give more comfort to the patient. Excessive respiration under splint silicones, elastomers, or bad quality of pressure material could cause also maceration, because there is some garments in the markets, unfortunately, and we have it here in Riyadh. If you use it, it's really causing a lot of sweating under, and this sweating could cause easily scar maceration. Also, accumulation of cream under the silicone or the elastomer could cause scar maceration. That's why we should delay using silicone. Most important to start with is scar mobilization and moisturizing, then apply pressure garment. And then if the patient gets used to those interventions and the skin integrity is high enough to apply the elastomer or the silicone, this is the time you can start silicone. And always confirm with patient that he should apply very little lotion. Any lotion in the market will do. If you use silicone, any moist, but not Vaseline, not oil. Only very mild lotion, not any expensive ones, because I've seen many patients who goes outside to the pharmacies, they give them like a moisturizing cream that costs 200 or 300 reals, which is really too much. Once we are using silicone, any lotion will do to give some moisturizing, and we should put very little. We should be sure that the cream gets completely absorbance before applying the silicone. The strong soap as well or cream could easily irritate the burn skin. That's why we usually tell patients use the baby shampoo to have the shower with, and also cleaning the silicone or the pressure should be with a very light hand soap, I would say. Silicone gel sheeting is very essential as well. Modality for a scar treatment. And silicone gel ingredients, it has, like some silicone, it has more than 29 types of ingredients. It has some herbal skin. So this is mainly the ingredients, as you can see in the screen. It has some onion extracts. It has also hydrocortisone, 0.5%, which is very little as well. It has some shea butter as well in it, so to give some moist. It has silicon dioxide, so it has a lot of ingredients in it. So what silicon do? Silicon is one of the two evidence-based scar treatment for scar management and scar prevention. It helps in hydration of the scar, changes the water balance in the collagen and reducing the blood flow to the scar. It's indirectly facilitating the necessary interactions between numerous cell types that create the balance between scar proliferation and scar reduction. And also stimulate repair of the dysfunctional top layer of the skin, covering hypertrophic and keloid scars. Also, it's increasing the over-adhesive content found in the scar matrix. Its silicone complications shouldn't be applied in open infected wounds, over scabs, stitches, or fragile skin. You should have a very good skin integrity before applying the silicone. Also, accumulation of ointments or cream under the gel sheets cause skin maceration. That's why we should have very little lotion, I would say, and be sure it's dry before applying the silicone. Silicone shouldn't cover more than 1/3 of the body surface area. Like if you have a patient with 60% burn, you cannot apply silicone on the 60% of the total body surface area, only 1/3 of the total body surface area. So I would say apply it on the badly needed areas than the other areas. In some cases, it causes some rashes, like a patient gets some allergy due to using silicone, and in that case, remove it quickly. Like you should tell patient, if this has happened, remove the silicone. The rashes, if it happened due to silicone usage, it usually happen in the good skin, not in the scar itself. So patient will have some rashes in the good skin surrounding the area. If you see in the photos, the container with the red cover, this is the elastomer. Elastomer is very useful on contracture skins, like in contractures for patients. For example, if you have an elbow contracture, knee, axilla, neck, it's really beautiful. And you can use, I know it's a bit expensive and it's really hard to get, but if you use it, you can use one. If patient is coming to you already contracted and you are working on him, you will use a new piece of elastomer in a daily basis till you get patient in a full range of the extension, for example. We have silicone tubes as well. You can see it's a silicone tube and fingers. So we have silicone tubes that start from finger size, and we have up to trunk size. You can have a silicone tube around the whole trunk. With some therapists, they says why we cannot get pressure padded with silicone. I know some companies will come to you and say, wallahi, we are selling a pressure garment that padded with silicone. I will never get that material to a patient. First, if patient develops some allergy to silicone, it means you will get rid of the pressure with the silicone. That's why better to have silicone sheets by itself and then pressure garment alone. If patient is not feeling well with applying silicone, this is the time you will have the pressure. Although we have this, as I mentioned, silicone tubes, we can apply it on forearm, upper arm, on the tibia, on the thigh, on the trunk. We can apply it under pressure garment. So at least you will have a separate silicone wherein you can wash it, or if you will use the silicone only 12 hours per day. But as I mentioned, the pressure should be used all day round. Scar mobilization and moisturizing, I would say deep friction massage, soft tissue release with moist. Moist is very important with massage because it promotes collagen remodeling by applying pressure to the scars. and it also helps with decreased itchiness. It provides moist and malleability to the scar. It increased tissue flexibility and prevent contractures by breaking down the cement or the matrix holding the scar contracted. It breaks up fibers in the scar tissues, and it desensitizes pain and hypersensitivity twice or even more if needed. And this will be decided by the therapist. Soft tissue release also have some complications, like friction massage mechanically stimulate fibroblast synthesis of collagen. Therefore, that approach must be combined with an anti-collagen synthesis approach to be of a significant benefit. For example, if you have a patient wherein he had, for example, a surgery and he's not ready yet for silicone, you cannot tell the patient to do deep friction massage on the scar till he will be ready for silicone. I would say only moist without massaging. I would say very gentle rubbing with the massage, but not deep massaging, because the deep massaging will aggravate the blood supply. So it means you are giving the scar more food to be raised. So I would say I will do deep massage if we have silicone, if you are applying silicone or pressure. There is a question here, what exactly the function of the pressure garment to the body in terms of a scar? Is it related to collagen? It's very related to collagen, I would say, because if you apply good pressure, not less than 24 millimeter mercury, it means you are decreasing the collagen formation. And you are also working on getting the fibroblast cells to reduce the amount of collagen they are producing. If you reduce the amount of collagen, it means you are reducing pain that patients will have. That's why pressure garment is very, very essential tool for scar management. And I would say in some hospitals, in purchasing department, sometimes they don't know that pressure garment is not just an elastic material that will apply on patients. It's a very essential. I always tell them it's the only medication for burn patients or patient scars. Pressure garment is very important to burn, like cardiac medication is very important for cardiac patients. You cannot have a cardiac issue or a gastric issue without medication. So this is the medication for the scar. So it's my answer, it's really affecting the production of collagen. So it lessens the collagen and also helps the fibroblast to only deposit the normal collagen. Then there is another question, how much tension to apply on Coban during scar management and how many hours should it be worn for? If I apply Cobaning, you can apply it in a daily basis, or you can apply it every other day. Like if every other day will be really good. And Cobaning, especially for pediatric, with my experience before with pediatric patients, sometimes when we use Coban, pediatric patients will refuse the pressure garment. So sometimes we go and teach the mother how to apply Cobaning. If you apply a type of silicone under the Cobaning, that type of silicone must be removed at least once a day, you will do it daily. We have another type of silicone called Mebifoam. That type of silicone you can keep on the skin for 7 days. You can use it under the Cobaning. So if you use it under Cobaning, you can apply it for every other day, considering the way you apply. So we apply high, like I would say 25% of tension distally. And then if you go down after the first phalanx, you will apply no pressure, because Cobaning is self-shrinking material. It's a cohesive material. It will shrink by time. So if I apply the Coban now and the pressure is 15 millimeter mercury, by the end of the day, it will give 24 millimeter mercury. If you leave it more than 2 days, the Coban gets stiff and gives very high pressure. That's why it shouldn't stay on the skin more than 2 days. If we use it with burn patients, and sometimes we start 10 days post-graft, but if we use it during that time, we apply a lot of paraffin dressing first, and after the paraffin dressing, sometimes we apply silver cell, and this gives more padding for the Coban, so the Coban will not be rigid on the graft. I hope I answer your questions. I'm more than welcome to receive any question at any time. Back to the complications of the massaging. As I mentioned, if you didn't start any pressure, if you didn't start any silicone, don't advise patients to do deep massage. We will do deep massaging if I will apply silicone or pressure or both together. But with burn patients, I would always say pressure. Pressure garment is very important. Moist, you cannot apply moist, of course, in open wounds. In that case, you will use Fusidine or some wound care products and some wound care coverage materials. And then you can do the massaging with the other surrounding areas. Perfumed or colored cream should be avoided. Perfumed because it's only irritate the skin, that's it. But it doesn't it will not. This is the only reason I will not use perfumed creams, because skin is still delicate and very sensitive. Colored cream, because colored cream always contains some artificial materials that we don't need as well. I would say lotion or cream with a very low perfume will be fine. Creams with vitamin E also shouldn't be used while you are working on active skin, because vitamin E usually has a peeling effect. And in that case, like the skin is newly formed, the graft is still newly applied. So we don't want peeling of the skin. So vitamin E, we cannot use it while the scar is still active. Oil or Vaseline shouldn't be used with pressure garment. First, it's oil and Vaseline, the viscosity of oil and Vaseline is very high. So whatever amount you apply, the skin will not absorb it very easily. This is number one. Number two, if you use oil or Vaseline with pressure garment, those materials are very greasy and it will stuck to the material. And by that, you will lose the elasticity of the skin. And if the elasticity of the garment, I'm sorry. And if you lose the elasticity of the pressure, it means you will, the amount of pressure will be affected. That's why oil and Vaseline, we could use it only directly after graft. But if we go to custom-made pressure, I will never use oil or Vaseline. This is also another thing. It's the same thing I've mentioned. Oil or Vaseline shouldn't be used for massaging, only very light lotion. Low-level laser, we use it quite a lot in our facility. So the laser we have is mainly 5 Newton pulse day laser. We mainly use it for wound closure, like if a burn patient develop a wound at any time, like during the 24 months of treatment or 35 months of treatment for dark skinned people, you could face wounds that occur at any time, like while you are treating burn skin, at any time a blister could happen. And that blister, once it opened, it causes a massive wound or hypergranulated wound. And if you use laser, this wound will be closed very quickly. We use it also to reduce scarring, but we are not using it with each patient, because if we use the laser with each patient, it means I need at least 10 therapists to work in the area. So it's mainly because of the staffing, also the validity of the laser machines. So it's working very well in fastening the wound closure. If the wound takes a long period of time, you can use laser machine. There is a new version of laser machine. It's called palm laser. It's a small laser machine, portable. You can use it even in the burn clinic with nurses if the wound is really aggressive and it doesn't close with using all types of wound closure materials. This is the time you can apply laser. It has very minimal side effects and treatment does comfort because patient doesn't feel generally with anything while you are using the laser, but you need to have the precautions of using it, of course. With laser, the precautions mainly with pregnancies directly on the eye. It's not allowed. It has a special glasses, protection glasses you need to apply. Also, if patient has a cardiac problem, you shouldn't use it near the cardiac area, near the chest. If there is internal fixation with patients who has cancerous cells or patients who have some cancers or wound due to cancer release or something, we shouldn't use it with those cases. You can see this is the scar laceration in the axilla, and you can see with laser what happened. Of course, we used laser, we use silicone in the surrounding area, and then we use pressure garment. But if you apply pressure garment, for example, in a case like this, the wound will never heal because the pressure will cause more digging. That's why it's very important to apply foam dressing, something called foam dressing. So you can apply Spinco foam under the pressure garment. This is a case who has been treated in Medina, and this is her thigh, and it took 4 months without healing, and the doctors offered them a new skin graft. So patient was referred to us from Medina, and this was the result after only 2 weeks, imagine. So 4 months, it doesn't heal, and this is after 2 weeks of using laser. If we go to the psychosocial rehab, which is very, very important input from our side. For pediatrics, you can go through playing, toys, you can go through narrating scenarios, through sharing other experience of burn patients. Like sometimes I used to tell my patients I'm full of stories because I used to tell them a lot of stories of our other patients, considering privacy, of course. Like I will not tell them their names or stuff like that, but I say, Wallah, we have one patient one day, and this patient has this. I will tell him a story about a difficult case, for example, so he will know. And sometimes I get the old patients themselves to come and talk to our patients. So they will provide volunteering work as well for those patients. I'm sorry, I need to answer one question here. How long is a pressure garment lifetime? This is a very good question because it depends on what material you are using. I'm not here to advertise for special companies. In National Guard, we are dealing with a material that if the patient's body doesn't gain weight or reduce or less in weight, the pressure garment set could be enough for the whole process. Imagine. I know that will not be happening in other materials, but the material we are having, there is mainly around 5 to 6 companies in the world that they provide pressure. 4 of them in Europe, and then there is one in the States. We are using garments from Spain that it has lycra, microcell cotton. It's a very nice material that we could recycle it after patients. Like imagine, I have some recycled pressure garments that patient use for 2 years. I get the garment, send it to the laundry and CSSD for sterilization, and then I use it again. I'm sorry, there is a well-known company that provides pressure garment, and it has a very high advertising in the markets on the internet. The pressure garment doesn't, to be honest, it doesn't stay more than 6 weeks. 6 weeks, and then you will lose the elasticity and the compression in the material. So if you lose the pressure itself, it will not be beneficial anymore. That's why the company, I would say, they says better to re-measure patient every 3 months, because every 3 months you need to order a new set of garments. But with our material that made in Spain, it's not one of the best, I would say it's the best material all over the world in applying pressure. It's very comfortable material. If patients wear it, he will say, sometimes mothers in summer, they are not putting the pajama on top of the pressure garment, thinking that the pressure garment will cause more discomfort with hot weather. But I have many stories from my patients that they says, when I apply the vest and the air conditioning is on, I feel very cold, something cold in my skin. And this is the best advantage of our pressure garment, that we are getting it from Spain. It has less seams, it has cotton, it's very comfortable. I have pressure garment, I would say, in the recycled box more than 4 years ago, and it's still keeping the elasticity and the amount of pressure it has. So as I mentioned, it depends on what material you are using. There is another garment in the market as well from Finland. I would say it's a very poor material. It doesn't give any perspiration. While you are taking it off from patient, you can see the amount of sweating that come out of the skin, and you can easily have a lot of maceration due to using this pressure garment. There was an important point as well. If you choose the company that you are getting pressure from, you need to be sure, are you dealing with a tailor or you are dealing with a factory? The factory will fabricate the garment without seams, like you will have a full glove without any seam, unlike the tailor will have a glove with a lot of seams. Same thing with the vest. The vest will have only seams in the connective areas, like on the shoulders, but no other seams in the garment. If there is a lot of seams, you should know that this is a tailor. It's not a factory that fabricates pressure. I hope I answered this question as well. If any more investigations, feel free to answer again. Back to the psychosocial rehabilitation, narrating scenarios, as I mentioned, it's very important to give other patients experience to your fresh case. Changing body image for patients, like could go through the modalities you are using, by silicone, by pressure. Also, if you regain function, patient will be psychologically better than if not. Pain control is very important, because if patient doesn't have good sleeping pattern, if the pain is irritating patient most of the time, he's gonna be really irritated, aggressive, and he's gonna have a lot of anxiety. That's why pain release is very important. If he's in inpatient setting, sometimes they give some pain control, but for the outpatient setting, sometimes they mainly give atarax. But patients always in our facility, they will have a lot of less pain because we apply early pressure. Like, for example, yesterday we have a patient who has massive wounds on the lower limbs. He's still under the dressing clinic. So what we do, after the nurse will do the dressing, we go and do AC bandaging on the lower limb. And then each time patient comes to the dressing, we do the same. By applying this, patient will have less pain and he will walk freely with no pain. Because especially with the lower limb, patient will say, once I stand up, I feel a lot of tingling, a lot of shooting pain in the lower limb, and also edema. But if you apply the AC bandages in a figure of 8 in the ankle and the knee, same way of applying it, like a distal pressure higher than the proximal pressure, and grading. While you are doing it, you are grading the pressure. It means you start higher and then lower degree by degree. Like if you start in the foot, you will do 50% tension, and then if you go to the ankle, you will go to 30% tension and go up 25% tension, and so on. Listening deformity also, it's really helping with the psychosocial rehab. If you can see, this is on the right-hand side, the photo in the bottom. This is a patient who refused to exercise completely, and she was screaming like crazy. So the only way to help her to move her arms was taking her to the gift shop. So indirectly, I've told her, Yalla, you choose whatever you want from the sweets and desserts and stuff. And I meant to ask her to get the stuff indirectly on the higher shelf. So in that case, she will raise her arm and she will move. And this is also good for her. So she will be busy more with choosing whatever she likes more than this. Also building up a very good relation and very close relation. I know sometimes they says, don't go deeply with patients psychologically. But I would say with burn patients, they are very exceptional. They are very exceptional than any other cases. Sometimes we'll go deeply with patients. Patients sometimes feel very comfortable with the rehab team more than any other thing. That's why we should find the way to go through even our functional activity through those type of socialization, I would say. Social interaction is very important as well. Like we have a yearly gathering with burn patients, burn victims. We have some patients 15 years ago, they are sharing with us those activities. And even in our booth, you can see on the right-hand side, our patients are our representative. So they are talking about the role of rehabilitation and how important that role is. Also, homework, school visits are very important. Like if you have a burn patient who need to go back to school, go back to work, it's very good as a completion of your rehab intervention is to do a home visit to see also accessibility, to talk to the family members about how to receive that patient, how to deal with him. You can go to work to assess the work area. If he is working outside in the sun, for example, you can recommend that some office work or something till he finished the scar management visits, wherein you go before that patient go to school. You can talk to the principal, to the teachers, to the colleagues. And I remember we have one time get together in a school wherein we meet in the morning with the whole school, and we've told the students how to deal with the new with their new colleague, because they will have another colleague, another body image of that colleague than different than before. They will receive a patient who is wearing a face mask, for example. So we need to be sure that those students will not cause any irritation to that patient. So they will deal with him normally. Like we used to say, oh no, this is, they will encourage him even to wear the mask during school time. Burn group therapy, we used to do that, but for the time being, of course, with the COVID-19, we're not doing that anymore. Burn group is very important, wherein you can get in the outpatient setting, of course. We do burn group, so patients will get together, so patients will not feel that they are alone. There is a lot of other burn patients that they could be around. Financial support as well is very important. As I mentioned before, job limitations is very common with burn patients. That's why sometimes we find some accessibility through social services and through also our support group. We have a support group wherein if a patient is having difficulty to find a job, or a patient who doesn't have good financial income, sometimes we help them through the support group to get some fund. We have volunteers, as I mentioned. We have patients that they're always willing to come and talk to fresh burns about their experience. They will show them how the skin is now looking after the years of treatment, of course. That's why the patient will know that his scar doesn't remain the same. No, there will be a lot of improvement, of course. Burn camps, and this is what I mentioned before, that we are really missing burn camps. They're very important. Maybe future-wise, it could be a project for us that we do burn camp wherein we get patients. For example, we can get like 30 to 60 cases and get them in a resort or in a hotel, wherein we can have some evening activities, social activities, get together, And in the burn camp, they usually have PT, OT, social worker, psychologist, and sometimes even the governor itself helping those activities. Associations as well, burn associations, I know it's very minimal, especially in the Middle East. Those associations, they should have a lot of activities for burn patients and a lot of fun, a lot of accessibilities, I would say, for burn patients. I would only, this is mainly slides that shows treatment for patients, like patients before and after our treatment. This is a case who came extension deformity of the wrist, flexion deformity of the elbow, hyperextension. Our result here after our treatment, I mean. So I've started with the elbow first, and then I go to the wrist, and then I went to the hand. This is one of my volunteer patients before, but unfortunately he moved to Medina. So that's why he's not our volunteer anymore. But this is also severe face burn. This patient was really compliant, and he went to work, imagine, with a full mask, full face mask, and he says, my face is my most important part. That's why I don't care what people will say if I'm wearing a mask. That's why was the result. Very nice result. This is a girl from Qasim who is referred with contractor as well. You can see how she improves. This is also hands. With this hand, for example, you cannot apply pressure straight away, but the best thing you do is skincare, skin mobilization, soft tissue release, deep friction massage, silicone, and daily co-banning, because you can see the web spaces are badly affected. And the best thing to deal with such hand is co-ban. This is one of my patients as well. You can see was one of the best results I've had, because the mother was very compliant. This is another case. You can see how the improvement is. This is one of our volunteers now. He was with me when he was a child, and now he's a staff nurse. This is severe face burn, you can see, and you can see the result after the pressure comment. You can see here in the mouth, because his mouth was really narrow, we cannot apply the ready-made splint. So this is fabricated by the OT. This is a very early phase treatment I've done. You can see that this is post-graft. You can see the contractures of the eyelids. And what I did a face mask, but before applying the face mask, of course, this is thermoplastic material, Polyflex. But before applying the mask, I apply wound care product, and then I did padding for the mask. So it will cause also, the padding will be like a shock absorber. So it will apply some good pressure, but it will not irritate the areas around the nose. You can see the eye opening after only the second day of the mask. You can see the eye opening. It's really a lot better. That's why I said pressure is very useful, and you can use a lot of easy to put on and offs. This is custom made pressure. This is the patient I've showed earlier, one of our volunteers before, and this is the pressure face mask he has, and this is the result after. You can see it's a beautiful result. This is another scar. You can see how the scar will fade, and the height will be lessened, and the scar will get. This is another patient from the north. You can see neck contractures, very firm scar, and you can see the result after. It's beautiful scar. This is another case who refused surgery, and we treated her with laser because the burn was really deep. And then she started with pressure vest and pressure garment and silicone as well. So you can see the result. I have a question here. ما هي الشروط للمتطوعين في مجال الحروق؟ احنا we are accepting متطوعين من anything, like I would say, even if you are not a burn patient, you could be a volunteer to come through our support group activities, or if you could come and do some financial support as well. Like we have some patients are doing some financial deposits for burn patients. Also, they do volunteering to come and give some advices to burn patients, or like it could be psychological or financial volunteering. And we go through our support committee, wherein we are with social workers and social services in our facility who are doing that activity. So we are accepting volunteering, and it's all focusing on the sake of the patient. This is a patient who has been referred. If you remember when I talk about pigmentation and burn that heal with secondary intention, this is a patient from the south, and his burn healed with secondary intention. It means it healed without surgery. You can see the hypopigmentation. I mean, this is mixed pigmentation. You can see some dark areas, and then there is a white areas. Unfortunately, future-wise, the quality of the pigmentation itself will not be good, like if patient has been grafted. But this patient was referred. You can see some keloid scar, hypertrophic scar with contracture of the axilla. So you can see buckets. There is buckets in between. So this is keloid with contracture, I would say. See here another photo of the same skin. This is after 1 week of our intervention. You can see the full range of shoulder flexion. And then this is after 2 years of the scar management. So the treatment really worth, because if you leave that patient without treatment, he will develop more contracture, and maybe shoulder abduction will be zero. Another patient of our and one of our volunteer, he was with us while he was a child, and now mashallah is an engineer. And this is him after we finished the treatment. Another patient as well from Qasim, you can see the results. And I would say this patient, because he lives in Qasim and we're in Riyadh, we couldn't go and do school visits, but he was very, very compliant. I've told him, look, Yahya, if you go to school without the pressure, you will have worse scar, and the sun will give more pigmentation to your scar. But he says, my scar is more important for me, and this is my medication. And he was really good in going to school with the pressure face mask. More than 80% burn. I would say there is no joint that has not been affected. All body joints has been affected very badly. And she was from Khamis Mashaid. And she was very compliant, and her family were very compliant with the treatment. And as you can see, all the exercises we do for pediatric, it's all through games. Like I will never go through direct exercises with those patients. So she has pressure, silicone, exercises. You can see the result after. It's worth it. So it means there is no single limitation in one joint. Although she was wearing face mask, gloves, vest, trouser, so it means pressure garment all over the body, but the silicone was mainly on the badly affected areas. It worth it or not? It's really worth it. Another patient of us, she has been referred with this massive claw hand. I know this was very challenging case. It usually takes a lot of time from me and my team to work with, but this was a result. You can see it worth it as well, but it's also still under treatment because the scar is still active there. But once you achieve the good extension of the IP joints and then the neutral position of the MCB joints, and then you can also notice here she has hyper extension of the CMC joint. If you have the right hand side result, it means the rest will come easily, because you can start working more with the flexion of the MCB and the opposition of the thumb. This is the same patient right hand, also severe. I would say it's not only hyperextension of the CMC joint, it was Seriously, it was a complete dislocation of the CMC joint, plus also severe contractures, extension contractures of the MCBs, flexion of the IP joints. If you notice, the index finger, the ring finger, and the little finger, they are not burned. But even though they are stuck, the BIBs is stuck in flexion because of the hyperextension of the MCB. But you can see the result now. It's beautiful result. And patient is using this hand almost fully now. Same patient who has severe contractures of the knee, severe contractures of the knee. And we started working with her gradually, but still, as I mentioned before, no aggressive exercises. We work with her only to get rid of the contracture without exercises. We did only work on the scar till we get the full extension. But while we are working in contracture releases by us, we stop the exercises because we don't want scar laceration or skin fracture. Because if you work with contractures and you do exercises, I'm sure you will fracture the skin. But if you get the skin in a good biliability, you will get the knee in a full range. This is the time you can start exercises with patients. Another patient of mine, severe electrical burn, and this was he has amputation of the left arm, and this is him after applying the prosthesis. I would stop for answering one question. Hand positioning recommendations for palmar versus dorsal hand burn. I would say for palmar burn, I will start with extension splint. It means the rest should be in 5 to 10 degrees of extension, MCB neutral, fingers in neutral, thumb in maximum radial abduction. And then that splint, especially with palmar burn, you can easily get flexion deformity for the hand, because we used to say flex, so very important for the full time of the scar management. Like if the patient, like other cases, I would say once we regain function in all joints, splints will be omitted. Like no need to wear splints. We are gonna work only on scar management, pressure garment, silicone. Only palmar burn, only palmar burn. The splint should be worn all nights, all over the 24 months of the treatment. Even if you start co-banning, if you start pressures, flexors, strength. Dorsal hand burn, if you notice in the beginning, when I talk about splinting, you should splint the hand in a posy position or safe position, we used to say. The safe position, it means the rest in 20 to 35 degrees of extension, MCB 50 to 70. I do prefer 70% of flexion, 70 degrees, I'm sorry, of flexion. BIP, DIB should be in full extension, and then the thumb should be in the maximum palmar abduction. Also, for exercises, as I mentioned, never exercise passively the BIP and the DIB. Let the patient do it actively, because with dorsal burn, the central slab tendon, which connect the PIB joint, is very thin and very close to the skin. And if it's sometimes with dorsal burn, it's burn as well. If you do passive deformity or is one neck deformity future-wise. Did I answer that question already? Like if you have more queries, feel free to ask again. Back to patients after completion of their volunteer. This case was severely burned and completely depressed, and he was really one of the most lovers and fans of this player. So I contacted him, and to be honest with you, I couldn't believe that the fast response that he told me, I'm coming tomorrow. And he said, please, I don't want any media or any advertising. I says, I don't want it either, because you are coming for the sake of a patient. You are not coming for advertising. and he came and he sit with patient at least 1 hour, and you can see really how much improvement that patient got, because he promised him that he will cope with the treatment and he will be better, inshallah, and this is what we got. So my conclusion, burn rehabilitation is a very challenging, overwhelming factors affecting burn patients. So the biopsychosocial approach and psychosocial rehabilitation prove to be useful in addressing issues faced by burn patients. Rehab programs should be patient-centered, ensure multidisciplinary collaboration, and address contextual issues. Sorry, there's a small issue with the slide. So psychosocial rehab is community-based rehab strategy. It's helping in restoration to optimal appropriate social skills. Need for psychosocial rehabilitation strategies in acute setting other than just social skill groups. So you are working from day one all over the treatment period with the psychosocial rehab. This is my references of the presentation, and I would thank you so much for listening, and I hope that we could have maybe future events wherein we can go through the full program. This is mainly a very concise rehabilitation process is for burn patients. And any questions? For rest, if I have a question, would you recommend same positioning recommendations if rest is also involved? What about circumferential burn of the hand? This is a very good question. Circumferential burn, you need to work with it as if it's a dorsal burn hand. Like circumferential burn hand, back to the theory that the flexors are more stronger than extensors, we still, with circumferential burn, we splint in safe position. Rest also should be extension, because if you have a circumferential burn and you splint patient in neutral rest extension, for example, patient will easily get more flexion deformity than extension deformity, because as I mentioned before, that flexors are more stronger than extensors. That's why I will still splint the rest in extension. Another question. What about circumferential? This is I also answered. With circumferential burn, I deal with it like a dorsal burn. Safe positioning or POSI splinting, extension of the wrist. Any more questions? Future educational sessions, maybe some hands-on. We can do hands-on together, and this is mainly to promote burn rehabilitation in the kingdom and on. Thank you.